Good morning. My name is Nadine, and this morning I'd like to provide you with a brief overview of my work from part 1 of this assessment for the unit Clinical Foundations for Practice, in which we examine the coroner's report of a client named JJKD, who we shall call Jack, who died by drowning while in the care of a community mental health service in 2015. Within the context of this case, I'll provide an overview of the coroner's report, the timeline of events, my own opinion of what may have gone wrong in this case, and then to conclude, I will discuss some salient learnings that could hopefully assist mental health nurses to manage these risk factors in the future. It was in 2008, September, that Jack had his initial engagement with a mental health service for a manic and depressive episode, resulting in a diagnosis of bipolar affective disorder. This was managed with sertraline, sodium valproate, and risperidone within the setting of the acute care team. In April of the following year, Jack's diagnosis is revised to schizoaffective disorder due to persistent delusions in the absence of mood symptoms, and he was commenced on quetiapine and lithium. Jack was admitted under an involuntary treatment order, ITO, for medication non-compliance and alcohol and drug use. Throughout May 2009 to August 13, care was managed by the Continuing Care Team, or CCT, and Jack was readmitted for 3 weeks due to a deterioration in his mental state due to medication non-compliance, non-attendance to his consulting psychiatrist, and suspected illicit drug use. He was then commenced on lithium and olanzapine. Throughout the period of October 13 to April 14, Jack's care was managed in the community by a community mental health clinic, CMHC, with psychiatrist Dr. IP as his treating physician. During April and May of 14, Jack was admitted under an ITO again and commenced on clozapine, and his case management was done by NURS20158. Through September to December 14, Jack was prescribed 300 milligrams of clozapine. His recorded clozapine levels at this time were between 70 and 450. February 15 saw his ITO revoked, and Jack continued to attend appointments voluntarily. Between March and July 15, his clozapine levels were consistently subtherapeutic, and they were only ranging between 90 and 150. This was attributed to medication non-compliance and misuse of alcohol and cannabis. On the 7th of August 15, Jack was planned for discharge from CCT to his GP and continued his monthly review with his private psychiatrist. On the 18th of August 15, his clozapine was increased to 400 milligrams. And on the 18th of September 15, he was found to be taking a subtherapeutic dose of 150. On the 29th of September 15, Jack was placed under an emergency examination order, otherwise known as an EEO, due to a self-harm attempt alongside cannabis use. Clozapine was reduced to 50 milligrams per month with the view to cease. Discharge planning to release Jack into the care of his mother was done at this time, and I think this is a significant event in the timeline and one that would certainly warrant an inpatient admission at this point. 30th of September 15, the CCT case manager visited after a call from Jack's mother concerning a low mood and that his clozapine dose was reduced too quickly. Jack was assessed to be low and moderate risk to himself and low risk to others. The plan was left that Jack would be seen by a private psychiatrist and a medical review was to be conducted. On the 6th of October 15, Jack's mother again contacted the case manager with concerns over her son's deteriorating mental state. He was increasing in paranoia and she was feeling the medication lacked efficacy. The case manager spoke with Jack and noted that his speech was slow and lethargic. Jack denied any plan in relation to suicide and he was booked for a clinic appointment in one day for review. On the 7th of October 15, he attended the clozapine clinic and unfortunately there was no medical documentation on record for that time. According to the CCT records, though, Jack denied thoughts of deliberate self-harm or suicide. His mother noted an increase in paranoia and recent use of cannabis and alcohol. The CCT case manager's impression was that he was suffering from depression without psychotic symptoms, precipitated by ongoing alcohol and drug use. The plan was to continue to decrease his clozapine dosage and re-refer back for community management. On the 14th of October 15, Jack attended a medical review, and it was noted he was suffering significant anxiety and negative symptoms of schizophrenia. The plan at this point was to decrease his clozapine and commence aripiprazole and psychotherapy. Jack's mother contacted the case manager on the 16th of October 15 with concerns regarding his mental state yet again, and a review was booked for the following week. 19th of October, he attended a medical review discussing the importance of medication compliance, and his clozapine dose was reduced from 100 to 50 for 1 week with a plan for cessation after that. Jack called his case manager on the 26th of October 15 to discuss his difficulty in sleeping and was to be reviewed again in 1 week. On the 3rd of November 15, a mental state examination was conducted, and Jack's risk was low to himself and others, but there was little evidence of improvement, and they thought due to medication non-compliance. The plan was to increase his aripiprazole and consider a depot medication and continue 1 to 2 weekly reviews. The 25th of November 15 saw Jack attend his review. He stated he's feeling better. On the 1st of December 15, CCT was made aware that Jack had been arrested and charged with being a public nuisance, trespass, and unauthorised dealings with shop goods in relation to an incident in a fast food premises. Without taking the recent events into consideration, the plan was left to review again in another 3 weeks. This is a significant event, indicating a change in his judgment and presentation that would warrant intensive investigations, in my opinion. Jack was again reviewed by CCT on the 19th of December 15. The plan was left to continue with CCT case management. There were no acute issues identified. 22nd of December 15, his mother had concerns about his cannabis and methamphetamine use and his deteriorating mental state. The case manager has at this point has an unsuccessful attempt at contacting Jack, and it was obviously another missed opportunity to intervene. 23rd of December 15, he attended a medical review where it was noted medication non-compliance, an increase in drug use, lack of insight, and poor self-care. A risk assessment indicated negligible risk of harm to self and others. Impression of ongoing positive and negative symptoms and deterioration in judgment were also documented. This was clearly another missed opportunity for increased surveillance due to his obvious mental deterioration. A depot injection of aripiprazole was administered, planning to continue weekly CCT appointments and a medical review in 4 to 6 weeks' time. The weekly CCT appointment did not occur, and this was discussed in the coroner's report. And then, sadly, on the 1st of January 16, Jack was found deceased in the ocean with coroner's findings of death by drowning. There were numerous occasions throughout this timeline that Jack required interventions and or an inpatient admission due to his deteriorating mental state and lack of insight. I feel that his mother, as his caregiver, was not listened to properly with her concerns. There were missed opportunities for psychoeducation to increase medication compliance. There's drug and alcohol issues that were not addressed, and his medications were not adequately monitored, in particular his clozapine prescription. There are also the various issues of lack of continuity of care and high caseloads for practitioners that may have also contributed to Jack's untimely demise. And this was all in the recommendations of the coroner's report. The salient lessons that can be reflected on from this timeline of sad events are that there were multiple missed opportunities for meaningful and effective interventions to avoid Jack's further deterioration and subsequent inpatient admissions. An effective therapeutic relationship alongside a continuity of care, caseload management, family involvement with care planning should all be considered. Also, there should be consideration of antipsychotic polypharmacy, which was obviously evident with the many different antipsychotics that Jack was placed on during this time. His care was suboptimal on numerous occasions, resulting in his premature death. And I think this certainly can be used as an educational tool to prevent a reoccurrence. Thank you for listening.